Welcome to my talk on bone scanning using sodium fluoride, 18F sodium fluoride. This lecture is only for educational purposes. I do not claim any original material. I will acknowledge my resources in the next two slides. My first resource is an article in Radiographics by Bastovoros et al. And I found it an extremely useful article. The other one is an article by Mick et al. In the American Journal of Rankinology. So without further ado, I would like to delve into the use of sodium fluoride PET for bone imaging, particularly with reference to bone metastatic disease. Now, bones are common site for metastatic disease in case of breast and prostate cancer. Sodium fluoride is not a new agent. It was approved in 1972 by the FDA. But the challenges at that time were uh, the right type of equipment, i.e., the scanners were not available, and hence it was not popular at that time. It did not come into use, and technetium 99M, MDP, and similar agents were the preferred agents in the past, but that's not the case anymore. The current PET-CT systems have a higher sensitivity and better spatial resolution, and that is why sodium fluoride has found or refound a use in the detection and management of malignant bony lesions, particularly metastatic lesions. Now, sodium fluoride PET-CT has increased sensitivity and specificity in bony metastatic lesions. Breast and prostate obviously are the most common tumors that metastasize to the bone. Other such tumors include thyroid, renal, and lung tumors. Now, these mets can be lytic, blastic, or mixed. And obviously, there is a higher incidence of bone metastatic lesions later in the course of the disease. Um, Only 1 to 2% of patients have bony metastatic lesion in the initial diagnosis of C of the breast, but by the time um, the patients have recurrent disease, one third of the patients have bone mets. The complications of bony metastatic lesions include pain, pathologic fractures, hypercalcemia, cord compression, and bone marrow suppression. Um, a few words about the chemical and physical properties of sodium fluoride. Now, sodium fluoride F18 decays by positron emission. As you all know, that after collision with an electron, 2, 5, 11 keV annihilation photons are emitted at a 180 degrees angle to each other, essentially along a line, and these are then imaged. The half-life obviously is 110 minutes. It is produced in a cyclotron by particle acceleration in a nuclear reaction from water enriched with oxygen 18. So the uptake of sodium fluoride is related to the blood flow to the bones and osteoblastic activity. Obviously, increased uptake will be seen in patients who have neoplasms and there is bone remodeling. FDG PET has high affinity for soft tissue neoplasms, which are hypermetabolic, and lytic bony metastatic lesions with high degree of sensitivity and specificity. However, the FDG's dependence on increased cellular metabolism results in limited sensitivity if the tumor is slow growing or if it is an osteoblastic bony lesion. Um, Bone scintigraphy with MDP has limited sensitivity for purely osteolytic lesions. On the other hand, lytic lesions are better characterized by FDG PET. So poor specificity of bone scan with the MDP and FDG PET um, in cases of non-malignant processes such as spinal degenerative changes. So there are false positives both with bone scan and with PET, FDG PET. Now, this illustration is about the way sodium fluoride is distributed, and as you can see, it has a physiologic biodistribution which is very similar to that of technetium 99M MDP. The only difference is that it has a better bone to background ratio. And the reason for that is that it has minimal binding to serum proteins and a very rapid single pass extraction and fast clearance from the soft tissue. The result is that there is 2 times more bone uptake by sodium fluoride than MDP. Now, because of all this, because of the better bone uptake and faster soft tissue clearance, it takes much less time. In other words, the patient does not have to wait for 3 to 4 hours, as is typical for a bone scan with MTP. And obviously, increased bone to background ratio and better diagnostic accuracy can be obtained. Um, Whereas with the MTP, you have to wait 3 to 4 hours. As a result, there is a better patient throughput, and you can do a scan quicker and faster. Because of that, less patient motion artifacts, you can image more patients, and obviously this results in a sort of a indirect way with better and quicker diagnosis, and obviously rapid diagnosis and initiation of treatment. um, the other advantage that is being touted these days is the fact that we are often suffering from shortage of technetium, whereas that's not a problem with NAF because they're producing cyclotrons. Now, I mentioned that there are areas where sodium fluoride has no advantage. It has low specificity like MDP, because benign processes also take this agent and cause false positives. But there is a better delineation and anatomic localization of the lesions with this agent. Now, this is a comparison table that I took from my reference in radiographics. Briefly, I mentioned that there is minimal protein binding with NAF, more with MDP. Spatial resolution is better because we use PET, whereas in case of MDP, the gamma cameras are used. Half life is 110 minutes, 6 hours for technetium agents. 100% fast pass, 60 to 70% MDP. Clearance is faster in case of NAF. And so imaging time is reduced. You can image within half to 1.5 hours. But the negative again is that we do not do dynamic imaging with this agent. Now, um, this is a image that I took from AJR, my second reference. And as you can see on the posterior image of a bone scan, there are some areas of abnormal uptake, which are metastatic lesions. When you compare it to the NAF on the right hand side, you find far many more lesions, multiple lesions that were not visible on the bone scan. So this is an advantage of NAF compared to a bone scan. Uh, Here is an example of a CT scan showing sclerotic bony lesions. And Now, if you compare the PET FDG on the left to the NAF PET on the right, you find again there are multiple lesions that can be identified with NAF compared to the FDG PET. This is an illustration of sodium F PET CT, where you can see multiple bony lesions, and so that's an advantage of sodium fluoride. I mentioned that it is not possible, or I won't say it is not possible, but routinely it is not possible to do a three-phase bone scan with NAF PET, because we typically acquire after 90 minutes, whereas typically we do bone scan three-phase imaging. Um, Now, this is a table that I took from radiographic article, and there are multiple indications that have been described. I'm not sure that all of these are practically used in day-to-day practice, but certainly it is a good thing to keep in mind that you can use sodium fluoride for all these indications. I'm not going to go into the details, but quickly, the first and the best indications, obviously, skeletal myths, then of course unexplained back pain, trauma, child abuse, bone viability, osteonecrosis, and metabolic bone disease. Now, I will briefly talk about the sodium fluoride PET CT protocol. So, immediately you can do, or before or after the emission imaging, you can do a helical CT. Typically, use 5 to 10 millicuries for those who like activity in megabecquerels, 185 to 370. For children, we use weight related dose, which is 0.06 millicuries per kilogram. We do not exceed 5 millicuries. And of course, whole body oncological survey, you use up to 10 millicuries. You can do emission imaging after 90 minutes, and we use 3D mode. Patients are supine 5 to 7 bed positions, 2 to 5 minutes per bed position. Certainly, if you are doing a whole body, you can add another 5 to 7 bed positions to include up to the toe. Briefly, 128 or 2 by 256 by 256 matrix. Some technical details that I'm not going to go into. Now, sodium fluoride is well distributed throughout the skeleton, and adequate images can be obtained without use of attenuation correction. Now this is a big no, because attenuation correction adds anatomic information and improves the accuracy between benign and malignant lesions, and also detection of smaller lesions. So it is recommended that interpretation should not be done without attenuation correction. And something to remember is that sodium fluoride accumulates in the renal pelvis and ureters and can cause streak artifact. That is something to be mindful of. No special preparation, no fasting, usual medication. Patient is requested to avoid before the lesion, before the scanning, and then of course there is going to be intense uptake in the bladder, so that can obscure pelvic lesions. Better to remove metallic objects. We encourage hydration as we do in MDP bone scan. To give you the type of effective radiation dose, it is about 12.1 millisieverts, whereas it is 7.4 for MDP. Remember that there is a component of CT that is also adding to the radiation here. Bladder receives the maximum radiation, whereas bone surface receive maximum radiation with MTP. The sodium fluoride is deposited at sites of increased bone turnover and remodeling, and metastatic lesions are seen indirectly because of the local bone response to underlying tumor. Now, most metastatic lesions will show focal sodium fluoride uptake, whether they are lytic, blastic, or mixed. So that's a great advantage in comparison with the bone scan or FDG PET. Um, I mentioned the same thing, and in case of osteolytic mets from breast cancer, you may see photopenic lesions with a peripheral rim of increased uptake, um, and so sodium fluoride can be used to detect bone mets that are not evident on FDG PET, and those that show decreased FDG avidity, such as mets from renal and thyroid carcinoma and well differentiated neoplasm. So, this is an advantage that you may not see some of these lesions on an FDG PET, but you will see that on sodium fluoride. I'm going to give you some examples again from my references in radiographics. Here is here is a PET study. FDG PET shows multiple bony metastatic lesion, but when you compare it to the sodium fluoride, you'll find there are far more metastatic bony lesions that are identified with the sodium fluoride study than with the FDG PET. Um, this is an example of a patient with breast cancer. This is a sodium fluoride PET study showing multiple areas of abnormal uptake, and you see on the corresponding CT scan there are sclerotic lesions in these locations. But you know this adds more information because it provides you far more details, as well as picks up more metastatic lesion that may or may not be picked up by other agents. I just showed you this image, and here is a lytic lesion, as you can see here, in a patient with breast cancer, and there is photopenia here, but there is peripheral uptake. So that saves you, and you can see that it is asymmetric compared, so that should draw your attention. And certainly the CT was helpful. So a lytic lesion that is being picked up. Um, well, it is important to remember that there may be discordant findings between PET and sodium fluoride PET. And again, this is an example where you see there is hypermetabolic left axillary nodal mets um, on the FDG PET, and there are no bony lesions identified, whereas with the sodium fluoride, you're seeing multiple other lesions, and this tells you that sodium fluoride can pick up far more lesions compared to the FDG PET. Now, the thing to remember also is that there are going to be false positives with sodium fluoride PET, and I'm going to show you a few examples. So You can use a sodium fluoride PET for detection of other primary carcinomas such as prostate, renal, and lung cancer. And this is particularly important in case of vertebral column, where it has been reported to be better than MDP. This is an example of a PET and sodium fluoride PET. And as you can see here, this is a FDG PET. There is a there is a lung lesion. There are hilar mets, and then you're seeing all these multiple metastatic lesions. And this is a lytic lesion that is being confirmed um, uh, on a lytic blastic lesion or a sclerotic lytic lesion, mixed lesion, that is being shown here on the CT scan, and you see how intense it is here. And obviously this vertebra is liable to collapse. So this scan changed the management. Here you're not seeing any bony lesions on FDG PET. Here you're seeing multiple bony lesions, and obviously that changes the management. um, so again, some pitfalls. It is not a tumor-specific agent. You can find positive uptake in arthritis, trauma, fibrous dysplasia, Paget's disease. So you have to look at the scan along with the PET CT, along with the CT scan. And this is an example of a patient with rheumatoid arthritis and all these areas of uptake on sodium fluoride, which with the PET CT are showing, we are seeing as being there in the joints, and obviously it goes in favor of this being a benign process related to inflammation and not because of a malignancy or metastatic lesion. This is an example of a patient who has on CT scan a typical appearance of polka dot appearance of a hemangioma with thickened bony trabeculae, but it is positive on sodium fluoride, and so you can't call it a metastatic lesion. Here's another example of a fracture involving the sacral area, which is very positive on the sodium fluoride, and this is something to be aware of. Another example, fibrous dysplasia on the CT scan, but intensely positive on sodium fluoride, and something to be aware of. Another example where this is a lesion that you see, it is a lesion in the liver, and it is showing positive uptake, and this is a calcified breast cancer metastasis that is picking up sodium fluoride. Um, this is a thrombus within the right atrium, calcified, which is positive. And some of these things that I'm talking about, you will find similar uptake on bone scans. This is an example of a calcified meningioma, um, which is positive on the sodium fluoride exam. And last but not the least, there is some uptake in the GI tract on the small bowel on a sodium fluoride. But looking at its shape, um, it's kind of curvilinear. That sort of goes in favor of it, this being a small bowel